right, so we are going to be talking today about the presentation and diagnosis of female genital tuberculosis. Right? I'm Dr. McLaughlin. I realized I should introduce both of us, so maybe I should say who I am. So I'm Stephanie McLaughlin, and both Dr. Church and myself don't have any conflicts of interest to disclose. Next slide. So the learning objectives for this talk will be threefold. Number one, identify populations at risk for female genital tuberculosis in order to expedite screening for TB and improve patient outcomes. Two, describe the diagnostic methods available for female genital TB to improve a timely diagnosis. And three, explain the importance of early diagnosis to prevent long-term complications of female genital tuberculosis. Next. So for this portion of the talk, I'm going to present a case that I saw during my first year of fellowship that really got me interested in this topic. And we'll use this case as a springboard to talk about diagnostics, et cetera. So this is a 36-year-old female, had never been pregnant, otherwise healthy, who immigrated from Ethiopia 12 years prior to this presentation. Upon immigration, she had had a positive PPD, but she was told by her PMD that it was from a prior BCG vaccine and not to worry about it. However, she was trying to get pregnant with her husband some years later and experienced infertility for 5 years before presenting for infertility workup. During her infertility workup, she was told she had blocked tubes by her GYN, and she had a hysterosalpingogram that revealed evidence of tubal disease with bilateral proximal tubal occlusion. And later in the talk, we're going to go over a slide that shows this on imaging. And she had no record of intrauterine abnormalities. So she, without any further diagnostics, she underwent her first round of IVF and got pregnant in 2017. Next slide. During the course of this pregnancy, she developed some vaginal bleeding at 16 weeks, followed unfortunately by a second trimester fetal loss from pre-prom and placental abruption. She had a dilation in a DNC that was performed for retained placenta. When the placenta was sent for PAC, it was grossly normal. An autopsy of the fetus showed the only abnormality was a cleft lip and palate, and nothing else was abnormal. After this first pregnancy, she experienced hypomenorrhea with both fewer cycles and a lighter flow for her cycles. She underwent 2 more unsuccessful rounds of IVF, and after these 2 more unsuccessful rounds, she transferred her care to a different IVF provider. That provider did an endometrial biopsy in 2019. So this is now 2 years after her first pregnancy and first IVF round. This is the pathology from her endometrial biopsy. And I saw this patient in clinic after this was found on PATH. So we'll kind of zoom in and show you what we're looking at here. Next slide. So here, you can see that this is ASE positive. So this is her endometrial tissue with stained tuberculosis. Here is another picture. It's not projecting great, but just another zoomed in view of the past slides. So as I said, she was referred to clinic, and I saw her during my first year of fellowship. I spoke with a pathologist about the biopsy. I spoke with her REF provider. They did a repeat biopsy that was ASE positive on culture. And she also, interestingly, had an ASE positive urine as well. So we had 2 different cultures to base our regimen on. So she got 4 months of RIPE, followed by 2 months of INF plus RIF for pan-sensitive TB. And after her treatment, she had further workup to look at her uterine lining and had some excision of adhesions from scarring from her infection, now treated. However, endometrium remained thin. So because she was never able to establish an appropriate uterine lining, the advice of her IVF provider, unfortunately, was to proceed with a gestational carrier, a surrogate. Next slide. So this is a really illustrative case about sort of one of the several presentations that we see of urogenital TB. So I'm going to zoom out for a moment and just talk about the prevalence here. So female genital tuberculosis accounts for about 15 to 20% of extrapulmonary TB. And in about, depending on where you get your statistics, up to 1/3 of cases are an isolated presentation in the genital tract. It's less common in the United States, as you might imagine, where it accounts for about 1% of infertility presentations. But in endemic places like India, it can contribute to half of all of tubal infertility presentations. So it's really highly on the radar of providers there, but not so much here in the United States. And the reproductive health implications of female genital tuberculosis include infertility from tubal and uterine scarring, as we noted in this first case, pregnancy loss, and also risk for congenital transmission, which I also saw an interesting case of congenital tuberculosis when I was a first year, sort of in the same setting, IVF pregnancy. Next slide. Here's just an image from a review paper that shows some of the growth pathology. You can see where the arrows are. That's where the tuberculosis has formed granulomas on top of the uterus and in the fallopian tube. Okay. So, as I said, infertility is one of the presentations where we can see female genital tuberculosis. It can also present in a couple of other ways. Some folks can present with chronic pelvic pain as sort of a pelvic inflammatory disease mimic, sort of abscess that's found because of chronic pelvic pain, or a pelvic mass can be thought to be a malignancy, and only upon excision is it noted to be tuberculoma. So female genital tuberculosis, because it mimics other disease processes and because it's much less common in the United States, is really underdiagnosed and underreported. So it's kind of a historic rarity. We do see case reports in the literature, and it's sort of underdiagnosed because of the complexity of the infection and our lack of definitive diagnostics, which we're going to touch on when Dr. Chan-Whitchurch takes over the second half of this presentation. The lack of diagnostics can lead to delays during fertility workup that can confer serious complications. And as I mentioned in the first case, this can be late fetal loss and can also, in rare instances, be congenital tuberculosis transmission. Next slide.
So I'm going to take over at this point, and I'm going to focus on the diagnosis and outcomes after treatment in female genital tuberculosis. I think one of the key things for starting with the diagnosis of female genital tuberculosis is that initial presentation is generally to OBGYN or maybe primary care. These women come in with complaints that don't necessarily bring them straight to the attention of a lot of us in infectious disease or other fields related to tuberculosis. So this is some imaging findings that are suggestive of female genital tuberculosis on hysterosalpingogram. And so these are some buzzwords that might lead an OBGYN to proceed with further workup. So things like beaded appearance of the fallopian tubes, constriction in certain areas, particularly between the isthmus and ampulla of the tubes, adhesions, deformity, or obliteration in the uterine cavity without any preceding history of surgical termination or curettage, and calcified foci or nodes in the adnexa. So this is hysterosalpingogram of a patient with female genital tuberculosis. As you look for the various findings on this, you see that there's actually complete obliteration and blockage of the tube on this side. There's no entrance of dye into the tubes on that side. And then on the other side, you see that there's multiple constrictions, which is this beaded appearance. And that there's actually some, where the star is, there is some leakage of the dye, showing an actual leakage out into the abdominal cavity from that side. So there's tubal disease on both sides in this particular instance, which is fairly common. And tubal disease is the most common location in which you see abnormalities, beyond more common than in the uterine cavity or other parts of the genital tract. So diagnosis of female genital tuberculosis. Endometrial biopsy is the usual standard for diagnosis. And part of the reason that these cases that Dr. McLaughlin was referring to made it so far in their course without having a diagnosis is that endometrial biopsy is not a standard part of infertility workups any longer in the US. So women can make it substantially far in their workup and treatment for infertility without ever having these invasive samples taken or looked at with pathology. So generally speaking, endometrial biopsy is collected, and the diagnosis is usually made by granulomas on pathology, positive AFB stain or AFB culture, and more recently with MTB PCR of the endometrial tissue. Sensitivity is fairly terrible for all of these things. AFB stain is about 34%, 52% will have classic histological features, which is usually granulomatous disease, and about 64% for PCR, although this is admittedly on a paraffin embedded tissue. However, if the OBGYN performing the procedure is not specifically looking for tuberculosis or other infectious etiologies, paraffin embedded tissue may be all you have out of the procedure. GeneXpert has good specificity, but actually fairly poor sensitivity. In-house PCR tests have had higher sensitivities in endometrial tissue, but have had variable specificity, making their routine inclusion more difficult. Expert Ultra may offer increased sensitivity, but hasn't been widely studied in endometrial tissue samples. There's also the possibility that this procedure misses the main site of disease. 90 to 100% of cases of female genital tuberculosis have tubal abnormalities, but only about 60% show endometrial abnormalities. And so if you only biopsy the endometrium and the areas of concern are tubal or ovarian, you may be missing the site of disease. So generally speaking, we recommend if there's imaging abnormalities in the tubal or ovarian areas and surgical specimens are going to be obtained, that those should also be sent for pathology, but also for AFB smear culture and PCR. There's been interest in non-invasive diagnostics since these procedures are not done routinely as part of infertility workups here in the US. So urine AFB culture and MTB PCR is one way that you might look for female genital tuberculosis non-invasively. As mentioned in our previous case, it can be positive. There are statistics available for male genital tuberculosis. About 50% has urinary involvement as well. Given the lack of direct connection between the urinary and female genital tracts, it's probably less likely in female genital tuberculosis, but the exact amount of correlation is not really studied or published in the literature. So the advantage of this, it's easy to collect. You can get it in the office. First AM urines are maybe possibly a little bit more sensitive, but generally speaking, this is a relatively easy test. Low sensitivity and can be high cost in terms of disadvantages. Another in diagnostic that's been under investigation is menstrual blood culture and or PCR. This is collectible by the patient at home. Sensitivity is estimated in comparison to clinical diagnosis and or endometrial PCR to run between 70 and 90%, so not bad. However, disadvantages, you have to wait until menstruation to collect. You have to educate the patient appropriately in terms of collection. Not all labs will run PCR on blood samples, so you may not be able to get PCR on this sample. And a lot of these patients present with menstrual abnormalities, and so they may have irregular or absent menstruation that makes collection difficult to do. So we've been talking with fertility centers in our area to try to set up an algorithm for referral for patients who come from places where there's a higher prevalence of tuberculosis and may be presenting with features suggestive of female genital tuberculosis. So we are encouraging them to identify patients who either come from TB endemic countries or have other risk factors for tuberculosis and have infertility with uterine or tubal disease. We're requesting that they get both a QuantiFERON and usually a PPD as well, but we're very much encouraging them if they have high clinical suspicion based on imaging or other reported histories that a negative QuantiFERON does not deter referral, and go ahead and get a chest x-ray if those tests are positive, and then have those patients referred to infectious disease. On first consultation, our algorithm, we send for menstrual effluent culture and urine culture and PCR. And then if those are positive, we would proceed to treatment. If those are negative, but we remain with high clinical suspicion, knowing that the sensitivity of these tests is limited, we would proceed to endometrial biopsy or other surgical specimen collection. Whereas if all those are negative, and we also deem that the patient is low risk from their imaging or other findings, then we would proceed to LTBI treatment. So treatment for this is nothing particularly exciting. It's the standard 6 months of RIPE therapy. Generally, if you have any evidence of drug-resistant disease, it's treated similarly to pulmonary tuberculosis. So the main point here is the consequences of delayed diagnosis. There have been multiple studies that have shown that the average period between presentation and diagnosis for women whose primary presentation is infertility is greater than a year. Patients who present with different presentations such as postmenopausal bleeding or abscess-like features tend to have earlier diagnosis because they tend to proceed to tissue collection at an earlier stage. But the likelihood of conception after treatment is very variable and can be range from 20 to 60% chance of conception post-treatment. But clear studies have shown that new PCR diagnostics and earlier diagnosis have shown that your odds of post-treatment conception are much better if earlier treatment occurs. So in conclusion, this is a disease where most people present initially to OBGYN. So it's, as we've run into, it's not on the radar of a lot of OBGYNs in this country because it is a rare cause of infertility, but the consequences of missing it can be devastating, both financially and personally to these women. So having a diagnostic pathway for women at risk could improve time between presentation and diagnosis and enhance people's chances of post-treatment conception and minimize other complications. Diagnostic methods are limited currently by invasiveness and low sensitivity. So keeping an eye out for features that are suggestive of this disease and having a high clinical suspicion, as well as using multiple methods for diagnosis, can help improve detection. Thank you.